we have over 150. I don't know what happened there. Anyway, we have over 150 people registered for the symposium, which is a tribute to our speakers and reflects the importance and seriousness of the topics that we will be discussing. Now, confidential reporting systems in surgery, CORESS, was set up over 25 years ago by a group of surgeons, many of them pilots, I think the majority were pilots, who were brought up with a reporting system which the Air Accident Investigation Branch introduced. And through their initiative, they inspired this group to do the same for surgery. The frank recognition that mistakes happen, the ability to identify what went wrong and to share that experience with others so that people can learn. And it's that continuing learning process, which is what CORESS is all about. I think that we have set up a very good system for identification and troubleshooting, and hopefully many of the people in the audience here today will have interacted with CORESS over the years. And may I use this opportunity to say that if you haven't done so in the past, I hope you will do so in the future, and you will continue to contribute your near misses. They are important, just as in the air, they are similarly so on the operating table. So that's a little bit about CORESS. Now for today, we have 4 excellent speakers who are going to talk to us. The first one is Dr. Kevin Stewart. Now, Kevin is the Executive Medical Director and Deputy Chief Investigator for HSiB, which is the Health Safety Investigation Branch. Now, HSiB had an interesting start that in 2019, Kevin came along with Keith Conradi, the Chief Executive, to see me in the House of Lords because they were keen to get the bill, the Health Safety Investigation Branch bill, through the House of Lords. And after sessions with cross-party peers, we managed to get that bill through, and it is now on the statute books. Now, Kevin, bless him, he works in Winchester, and during the course of the pandemic, took 3 months really at the coalface at the hospital. I live not very far from Winchester. We're literally about 5 miles away. So I know the effect that pandemic had on all those who worked at that hospital. He was medical director and deputy CEO of the Acute Trust in Winchester until 2009, and then spent a year at the Health Foundation Quality Improvement Fellow at the Institute of Healthcare Improvement in Boston. So he has a very good background in patient safety work or clinical audit databases, etc. And while he was in the States, he also undertook a master's degree in public health at Harvard. So Kevin is a well-qualified person to start us on this series of talks today. And I hand over to you, Kevin, to make your presentation. Thank you.
Thank you, Bernie, and thanks for the kind words and the bio, which sounds like something my mother would write. So I appreciate that, and I'm very grateful for the opportunity to speak today with CORESS. Several folks, obviously yourself included, have been very important players in getting HSiB to where it is today and establishing the organization, and we're very grateful for that. And as you've alluded to, we've got legislation. We'll talk a little bit about legislative process in a moment. Can I just check, maybe Bernie, you would just give me the nod that my screen is sharing okay? Okay, super. So thank you folks for inviting me, and I've tried to focus the talk, because we haven't got terribly long, on a recent report that we've done into Never events, hence the title. But I'm going to give you a bit of background to the Healthcare Safety Investigation Branch before that. We were actually established and became operational in April of 2017, and we were operating under parliamentary directions from 2016. The chief investigator had been previously the chief investigator of the Air Accident Investigation Branch. So that gives you a flavour of the ethos behind the organisation. And the ethos really was to learn from other industries. I'm sorry, my phone is going. To learn from other industries about safety investigation and try and bring some of those skills into healthcare. We'll talk a little bit about the parliamentary process and what was supposed to happen and what has actually happened in the meantime. But these are just a few lines lifted from our parliamentary directions, which are the rules under which we operate. We have to investigate accidents or incidents with evidence risk of patient safety. Specifically, we are precluded from apportioning blame or liability or other fault-based actions. That's really helpful for us. It's the ethos we would all like in investigation, but we can't do that even if there's an inclination to. We are tasked with developing skills to help improve local investigation, developing education programs and other things, and to operate independently of the rest of the healthcare system. And that was why there's proposed to be legislation to give us that status. But unfortunately, that's been delayed for a number of reasons. We have a small budget and we're a small team, a core team, to investigate up to 30 investigations a year of patients in NHS funded care in England. We get referrals from everybody, including from CORESS at one stage. We have a lot of links with people in lots of organisations that we sometimes pass stuff on to. But we've had referrals from members of the public, from clinicians, from medical directors, nurse directors, coroners, patient safety teams, and then items that turn up in safety databases or the press or somewhere else. We tend to make our recommendations not to individuals or individual trusts, but to system level bodies, and that might be NHS bodies or colleges or manufacturers or regulators, and MHRA and other organisations that we think can influence how to change the system at a wider national level, rather than focusing on individual trusts or indeed individuals. There is a provision which we are seeking in our legislation to give us the same sort of protections for evidence that people give us that those working in aviation or other transport sectors have. And that's what is referred to as a safe space. So functionally independent, we have full-time investigators. We take, as I say, Keith is from the aviation industry. I'm the medical director. I'm a physician by background. We have people from healthcare. We have people from the military. We have people from academia, from safety science. We have people from NHS management. We have legal people. Our investigation methodology is based on human factors and systems approaches, using a just culture approach, and we'll talk a little bit about that in a second. As I've said, not to attribute blame or liability. One of the last bullet point, if you like, the most important, we have been asked very specifically to be responsive to patients, families and staff. That's because a lot of the evidence that went to the select committee that was involved in setting us up was from patients and families and staff. The patient and family saying investigations were going on and they didn't feel that they'd been included or their views taken into account, or indeed their narratives taken into account, and staff from saying what we probably all have said at various times: I've reported something and there's been an investigation, but I heard nothing or I saw no change as a result of it. So we've worked very hard on that last point. This is about the safe space provision for protect disclosure. I can't see other people on the screen, so I'm assuming that people can hear me and that somebody will tell me if there's a hitch or something technical is not going right. Safe space provision for protected disclosure. So I know there's a lot of folks who have an interest in aviation here. You'll recognise the HSiB report on the Shoreham air crash, which happened in August 2015. The report came out in 2017. Keith, who's my boss, this is the last investigation that he was involved with the Air Accident Investigation Branch. It's an interesting story to tell, but we don't have time to do it here. But effectively, HSiB had to go to the High Court to protect the statement that the pilot had made to them from being disclosed to the police at the time, because the police wanted the statement. That was pretty controversial. It didn't mean that the pilot was above the law. People who have followed this case will know that the pilot was subsequently interviewed by the police under caution and was prosecuted. As it happens, he was acquitted of any crime. But these are similar powers that we are seeking for the people that we interview in healthcare, because we believe that the fear of speaking up to an investigation and that being disclosed to a regulator or legal authority or somebody else, or managers within organizations, is a big reason why people don't. So that's a provision that we have in our draft legislation, which we are hoping will become law pretty soon. Bernie referred to the various attempts we have had at getting legislation passed. In fact, Bernie, before the 2019 one that you were involved with in the Lords, there was draft legislation which was about to go in the Queen's speech in May 2017, which was our timescale, and then there was a general election, which was to do with the Brexit politics in Parliament at the time. And Bernie, the attempt that you were involved in, where it got to a healthy stage in the Lords, the following day or the day after, the Prime Minister also called a general election, which we think has probably also got to do with Brexit, and therefore the legislation unfortunately didn't progress past that stage. Very shortly after that, of course, COVID came along and preoccupied everybody for quite a long time. But in the current health reform legislation, larger health reform legislation, there is a provision for our legislation to be included in that. And the latest intelligence we have, first of all, is that it will be very similar to the legislation in 2019, and secondly, that it's likely to be introduced into Parliament towards the end of June of this year, so in a few weeks' time. So Bernie, I may be on the email to you when I know more about that, because obviously we've been very grateful for the support we've had from medical and clinical people right across the political spectrum. And I should say that the whole concept has got very good cross-party support. So it's not really it's not really one side or the other pushing this. It's got broad support in Parliament and from the public and from professional bodies. So it's a little bit about how we investigate. I work with quite a lot of people who are very clever safety scientists, and they don't like my oversimplification of how we investigate, but this works for me. We think about when things go wrong as somewhere between the sharp end and the blunt end. The sharp end is literally often the sharp end. It's the person with the knife in their hand or the needle. The clinical teams where something bad happens on the day and at the time. And unfortunately, most safety investigation has focused on that, and most changes recommended from most safety and patient safety investigation has been directed at individual clinical teams and the very local circumstances. And that has limited potential for changing the system across the piece, and it has actually limited potential for improvement. The blunt bend, I'd put at the other end of the spectrum, earlier and somewhere else, and that's about decisions that were taken before and in a much broader context, but affect how we all work at the sharp end of at a clinical coalface. And then the middle bit is local and departmental issues. I've put in just a little illustration of this. During the early stages of COVID, probably about March or April last year, we trusts, as you know, use the National Early Warning Score for patient deterioration on wards. It became very clear with COVID-19 very quickly that a change in oxygen saturation, if you remember, these patients deteriorate really, really quickly. They appear stable, and then suddenly their oxygen saturations fall, and they still look okay superficially for a short period of time until but those folks need ICU treatment very quickly. We found that this was getting missed on the wards all the time. I was involved in several of these cases myself, and therefore patients didn't get escalated for ICU treatment until they were much sicker than they might have been otherwise. So we looked a little bit at this very quickly and found that and played in all the influences that led to this environment. So the National Early Warning Score is supported by Royal College of Physicians and national policy, but there were lots of other things going on during COVID, including that this was a different disease that behaved differently from anything we've ever seen before. But if you see what I've put in it, individual preconditions for, we had inexperienced staff who normally did something else for most of their week, like me, but also were working in community settings and other things. Staff who were having to work in PPE, to which they were unused. HALT is hungry, angry, late and tired. I know we've got an MDU person on the call, but I stole this from the MPS. You know, the stress of caring for COVID patients and working was something we didn't really know very much about. Was a factor. People were often working in new ward environments. They weren't necessarily familiar with the equipment. The equipment was different, and so on and so on and so on. So you can see how we've sort of built up a picture of everything that led to the Unsafe Act. And in fact, our report didn't function on the Unsafe Act at all, because that could have been anyone at any time involved in that. It just happened to be the individuals who were involved in this one. So that's really just an illustration of human factors-based investigation systems. I know Peter's going to talk about human factors later on. Human factors and systems-based investigation systems that are generally focused on taking our eyes away from the sharp end, the Unsafe Act, into what's happening in the layers behind that. And there are various types of different approaches to investigation that have built up behind that. They all have a similar sort of approach. This is the one that we favor at the moment, which is called CEIPS. Pascal Carrion is at the University of Wisconsin. It's not such a linear layout, but you get the idea. So and when we come to making recommendations from these reports, we therefore focus in on this hierarchy of controls approach. So basically, if you look at the right-hand side, the triangle, the inverted triangle, this is about another investigation we did on transmission of COVID in hospitals, and the inverted triangle shows the most effective barriers at the top and the least effective at the bottom. And this is taken from the Health and Safety Executive. You'll see when we end up relying on PPE, which obviously a lot of stuff in the news today about it, the Health Service does a lot. We've actually missed a lot of other layers that we could have built in protections for. And we'll talk a little bit more about that when we talk about never events. So that's basically the ethos of the investigation, the ethos of the organization, the approach we take to investigation, and how we think about it. That bit of the talk could take 24 hours solid, but I appreciate we're very tight for time. Oh no, sorry, I've put in one little bit more about forcing functions. You'll see in this slide here, we've talked about engineering solutions. So use of equipment to prevent the wrong thing happening. I've put in a couple of slides now that I know I'm talking to a surgical audience, so I thought I'd get away with this, but I take this out for some other audiences. So people who travel on trains, which I used to do a lot before lockdown, come to understand that there's a problem if people flush the loo while they're on it, and so you get these signs: please do not push the flush button while you're sitting on the bowl type thing. And this is on Southwest trains, but of course they've got a sign, they've got a barrier, they've got something explaining why it's a bad thing. And you know what? People still end up suffering injuries and problems because of the effects of that. I won't obviously describe those injuries. So that's okay. It's a sort of it's a reminder. It helps to a level, and we can all think of clinical practice examples where that happens as well, but doesn't eliminate the problem. On Virgin trains, I happen to notice that they've put the button behind the lid, so it is actually really difficult to sit on the bowl and push the flush button. You have to get off it to push the flush button. I know that's a rather crude design principle, but you get the understanding. Actually, people still do manage to push the button somehow, so it's very difficult, as I'm pretty sure we'll hear later, to design out all problems. But that one is the Virgin trains one is an improvement on Southwest trains, and that's just an underlying principle. Excuse me. So we've done quite a few investigations. I can't remember how many we've done now over the last few years, but we have ended up investigating quite a lot of never events. And folks on the call would be very, very, very familiar with never events and very familiar with the aftermath of never events. And we decided to look at 10 of these that we looked at in more detail and reanalyze the data that we collected to try and understand what was going on there. This work was not led by me, it was led by my deputy medical director, who's Sean Weaver, who's a gastroenterologist in Bournemouth. And Sean was on the board of the trust, and he said, first of all, when you have a never event, it is, you know, as an individual surgeon or an operator or an endoscopist in his case, it feels very personal because it often is very personal. There's often a sense of blame, but if you have a series of never events as a trust, then that tends to create an atmosphere around the trust that again feels punitive. So we decided to look at these things and determine whether they really were never events. Never events are supposed to be incidents that are wholly preventable, where guidance or recommendations provide strong systemic barriers, are available and have been implemented. So that's the definition. I've picked out myths about never events. I don't think any of these things are supported by evidence, but if somebody on the call knows that there's evidence that could send me it, I'd really appreciate that. First of all, there's a myth that never events should never happen. The barriers, most of the barriers that we have found are not strong and systemic, so never events will continue to happen. There is something in the psyche of our healthcare system that says that increasing numbers of reported events means something bad. But we all know about reporting, and we know that increased numbers of reports could be something good, it could be something bad. You can't interpret numbers of reports as meaning particularly anything. I think there's also something particular about clusters of reported never events. So I've seen this stuff, and I experienced this when I was medical director in Winchester years ago. If you had 3 or 4 or 5 never events all in quick succession, that was supposed to be an indication that your trust had what is called a poor safety culture. I would seriously dispute that. I think you're comparing, I don't think you're just comparing apples and oranges. I think you're comparing, you know, anything you could buy at a supermarket, really, apples, oranges, bottles of detergent. Never events are as diverse as wrong side surgery and you know, somebody falling from an open window. And I'm pretty sure that naming and shaming, which seems to be a strategy, often seems to be coming from the top of the NHS, is not a helpful improvement strategy. I think and some of the stuff we see every year when never event list comes out in the newspapers, especially local newspapers about the local trust, I don't think is that helpful. So we've investigated, we've done 7 never events over 10 investigations. This includes 96% of those that are reported. Slides say occurring, but I've modified that to reported because I'm pretty sure lots don't get reported. And we were intending to make recommendations to see if we could increase our impact and improve the management of never events. As you'll see, we've just said numbers of never events reported is you know, this graph is fairly meaningless. It tells you number of never events reported, but it does pick out what the major ones are, which folks on the call would be really familiar with. We've analysed these using the SEEPS model that I showed you earlier. I actually don't like it when people do what I've just done, which is put up a slide and say, I don't expect you to read this. But it's really just an illustration of our analysis of the events and how we broke it down. So there's you'll see there's the individual stuff about the individuals at the top, and staff fatigue, team factors, interruptions. There's something about noise comes up, something about the task itself and how straightforward it is, something about the tools, the technology, the environment in which people are working, the wider organization, and then the external environment. If you think back to that blunt end, narrow end thing, sharp end, blunt end thing, they're pretty much, that's pretty much the same spectrum, but laid out in a different way. And in our analysis, we've got a clever computer program that'll do this. We've mapped the factors that came up in various of the investigations to all these factors, and you'll see there's multiple factors in each, as you might expect, and it's not really just a matter of something simple like a checklist or a reminder. This is one that we have looked at, which is not a surgical one. I deliberately chose a non-surgical one. It happens that patients get given medication, drugs that were intended for oral administration, so liquid medicines. It happens that these get injected into veins. The most common one for this to happen is actually Oromorph. And the Royal College of Emergency Medicine put an alert out on this a couple of years ago. In emergency departments in a hurry where patients are supposed to be administered Oromorph orally, they end up having that injected into a vein. The case that we investigated was actually midazolam that was injected into a vein in a child. The design of there's a purple syringe which is being designed for enteral administration, which is difficult to connect to IV connectors. Therefore, that's supposed to be a barrier. But what we found is that isn't a barrier. The members of staff involved in the event decanted the liquid from the purple syringe, not knowing what the purple syringe was for, and therefore the liquid got injected into a vein. Our investigators, I won't go into this in any detail, but our investigators have looked very clearly at the storage of the medicines, which is a bit shambolic, but something people will recognise from every ward in the NHS, and the storage of the syringes. And again, these enteral syringes are completely mixed up with the storage of other syringes. And folks like us don't really see where the syringe comes from. We just see the syringe in front of us. We got a human factors expert from the Navy to look at this for us, and he broke down the process. And it's probably hard to illustrate in the diagram, but everything about this barrier was dependent on the staff knowing that the barrier exists and how it was to be used. So every alleged barrier in this process was dependent on one point of failure. And he said, of course, nobody nothing designed in any other industry would rely on a single point of failure like that. And of course, the system failed. And you'll see at the bottom, we've talked about performance shaping factors: fatigue, stress, design, storage. This event actually happened on the first Wednesday in August, a number of years ago. So everybody on the call will recognise the stresses we have on the first Wednesday in August when junior doctors change over. So another one we've looked at is there's piped air on hospital wards as well, alongside piped oxygen. This was traditionally used to drive nebulizers. It was supposed to be removed following a safety alert a number of years ago. It is still present, and in fact, during the COVID pandemic, where we were using a lot of nebulizers and a lot of oxygen, a lot of piped air was used, but inevitably the air supply gets air supply gets connected to the oxygen tubing, and the patient suffers hypoxia as a result. One of the big barriers we found to people, to trusts removing the oxygen, was those working in PFI trusts it costs them a lot of money to alter the real estate. So that's another illustration of how a strong systemic barrier doesn't exist. Sorry, I'm conscious that I'm probably pushing my time limit a bit. So the report was published in January this year, 21st of January. I think it's on our website, hsib.org.uk. To cut to the chase, we found there were lots of themes contributing to the Never events. Most of the barriers were neither strong nor systemic. They relied on points that were going to fail, and mostly they relied on individuals doing something or following a process. And I don't know whether Peter will touch on this later on, but when you rely on individuals doing something or following a process, one of the things I've learned at the HSiB is anything that relies on individuals getting it right all the time is bound to fail. Because we are human beings, we will fail. And that's the nature of being a human being. It doesn't mean you're not hardworking. It doesn't mean you don't care. It doesn't mean you're not paying attention. It doesn't mean you have been to a good enough medical school or your postgraduate training is not good enough. If you're a human being, we can make you fail under the right circumstances or the wrong circumstances. So anything that relies on human beings is a weak point, and hence that the hierarchy of controls. We found, we said common themes about decision-making, team factors, interruptions, very, very common, and you folks will experience that in theatre, of course. To design of technology and the work areas, and we've done a big investigation into COVID transmission in hospital, and it's fascinating. I don't have time to show it today, but we have followed people around and looked at the interaction between professionals. There are hotspots in wards where people interact with each other, and guess what? Those are the places that they can transmit infection from one to the other. There's stuff about, we looked at an intraocular lens and the there isn't auto population. So once the lens was selected in one computer program, it didn't automatically populate to the subsequent computer programs. So the surgeon got the wrong lens for the wrong eye. There were versions of the surgical safety checklist which weren't standardized, therefore the locum surgeon didn't recognize the checklist that he was working with. Less common ones, we've unearthed some stuff about staff fatigue, but I think it's an area we need to get into more. But this is a very big area in other industries. I don't know if people remember the paper in the BMJ a number of years ago saying about fatigue and work performance, and it was, are trained drivers safer than doctors? Because they have far more regulation around their fatigue, but other things, familiarity with the task, demand, and we've said demand influencing performance. When you have got to get through a procedure to do the next one, to do the next one, to do the next one, that obviously affects your performance at the time, but we don't seem to take it into account in healthcare. So just a quick word on checklists. Ken Catchpole wrote this in the BMJ Quality and Safety a number of years ago. They promote safer practice, but they're not a strong systemic barrier. We could talk forever about checklists, and I'm sure lots of people want to. They are generally seen as a good thing, but they are not a strong systemic barrier, and they do not make something wholly preventable, which you folks will all know. So we've concluded that many of the commonly occurring never events should not be never events because they're not strong systemic barriers. We have recommended to NHSEI that they remove these from the never event list, but we have also said these are important and serious things. So ideally, what you should do is commission research to find strong systemic barriers to these incidents. So we are awaiting their response to that, but that's what we think should happen. We've looked at various other things in that investigation as well, including standardization and local modification of procedures. But I think if it's okay, I will finish there, and I hope we've still got a couple of minutes for a few questions. So I will just stop sharing my screen if that's okay, and hopefully I'll be able to see people. Thank you.
Well, Kevin, thank you. Is that
okay, Bernie? Much. I'm sorry if that was a rattle through.
No. That was perfect. Thank you very much indeed. I've not been very good at organising this meeting because Frank Smith was going to show some slides as well about CORESS and what CORESS does. I think if you're happy, and I've seen your note you sent me, perhaps between the two speakers we might do that rather than at the end, because we may lose people as time goes on. Now, there is a chat function, as you know, for anybody who would like to ask questions of Kevin, and Frank will be looking at that and moderating that. If you don't want to ask those questions immediately, we could, of course, pull some questions at the end. But Frank, over to you. Anything coming up?
Well, I just actually have a question for Kevin. Thank you very much, Kevin. That was very erudite, very well timed, and a very clear talk.
Sorry, I realized I had more time than I thought I had, but that was because you were squeezed, so I do apologize for that.
No, that was perfect. We actually had a CORESS advisory board meeting this morning, at which we discussed about 10 historical injection errors that had cropped up, and there were people from all the specialties there. We've probably got double that number in our records. When somebody wants to bring something to HSiB, they recognize there may be a problem with something. How do they do that, and how is that vetted?
Great question, thank you. There is a form on our website that you can complete, but we get notifications through lots of other ways, including emails to me, or if you email me kevin.stewart@hsib.org.uk, then I can put it into the system. And we are really keen to get referrals from people at the sharp end, like the folks on the call. For yourself, an email to me would be easiest, but it is on the website. There's a referral form. They are vetted. We have a referral process which we vet those every week. There are criteria against which we we judge them. I lead that process, and there are criteria against which we judge them, which is, the degree of harm or potential harm, the degree to which this issue is systemic, as opposed to, very uncommon or likely to be occurring in one place, and the learning potential. So something that is not obviously got a high degree of harm or potential harm is difficult to move through the process given our limited resources. We would search national databases and other things to determine how systemic or otherwise this is, but also research literature and other things that have been done in the past. And then learning potential is affected by a number of things, including our ability to investigate this issue at this time. We get quite a lot of referrals from bits of healthcare, probably particularly in mental health, where we don't have the expertise internally to do justice to some of the things we get contacted about. But also, if there's a public inquiry going on, or if there is an investigation by a college, or King's Fund or somebody else, then we would tend not to investigate something where there's a parallel investigation. But specific things that come up for you, then coming directly to us, then we will put it through our process. And if we can't investigate at this time, we put it into our intelligence database, because quite often 6 months down the line, we'll get something from another part of healthcare completely and recognize it as the same underlying issue. Does that help?
That's very helpful indeed. Thank you very much indeed, Kevin. Now, there are no more questions in the chat at the moment. I suspect it's because everybody's just getting used to that, how to ask questions. And if you do have questions for Kevin, please put them into the chat. I feel slightly uncomfortable with this, but I will do it. I'm just going to share my screen for one moment, because Lord Ribeiro has allowed me to. And what I would just like you to note is that although CORESS isn't directly taking part this afternoon, the role of CORESS is safety in surgery. We are a charitable organisation working with the 4 colleges and all the specialty associations. And we're very grateful to the 4 speakers today who represent their own safety organisations. We do have a website. This is a snapshot of the web page this morning advertising this seminar. And if you want to report adverse events or near misses, you can do that at www.coress.org.uk, and you can report online incidents. And I would emphasize once again, just as Kevin has been talking about, the ethos of the whole organization of CORESS is confidentiality and working towards a blame-free culture whereby adverse incidents and near misses are reported as educational vignettes for the benefit both of surgeons themselves and surgical teams, but of course principally for patient safety. So really that's the only plug I wanted to make for CORESS. Thank you for letting me do that, Bernie. Okay. I will stop sharing and ask you to introduce our next speaker, if I may.
Before we do that, a couple of hands have come up, actually. I noticed Jerard Ross wanted to ask a question. Jerard?
Thank you, Lord Ribeiro, and thanks, Frank. And Kevin, very interesting. I've heard you talk before. Thank you for that. There were 2 things. Firstly, I'm not sure the chat function is working, Frank. I tried to ask a question during Kevin's talk and didn't seem to allow me to do so. And the second question is for Kevin. I know at the moment you spend a lot of time as an organisation in HSiB concentrating on obstetric cases. Is there a plan to move more systematically into other areas in a similar way?
Yeah, I didn't speak about the maternity programme at all. That's a completely separate programme that we host, and we've done a lot of good work in that space. We don't envisage in the future, we won't, well, in the last legislation that came to Parliament in 2019 that Bernie was involved in didn't include HSiB continuing with a national maternity programme like that. We are led to believe that the next legislation, which is about to be introduced, won't do that either. So I think we've done some good stuff in maternity, but I suspect there'll be different alignments with maternity, and we will focus more on the more systematic stuff.
Now I see that Narinder Kapoor has got his hand up as well. Narinder?
Yeah, thanks very much. First of all, thank you very much for an excellent talk. I really enjoyed that, and I like the Northern Irish accent. I think it's similar to mine. I just, with a few colleagues, I appreciate this is not maybe a direct question, maybe indirect, but I did publish an article a few weeks ago in the Health Service Journal, where I made two suggestions. I pointed out that staff well-being and patient safety are quite closely related. And I know that HSiB maybe doesn't have the resources to look at staff well-being, although I did make that as a suggestion. But the other point was having directors of patient safety and staff well-being in trusts and having somebody there. And the idea would be that they would learn lessons from HSiB and CORESS and maybe link in with HSiB, etc. So do you think that that is something which something that HSiB would be helpful or could promote?
Yeah, I read your piece in the HSJ actually, because I found it very helpful. I think so yes, obviously we're very supportive of that approach. We are limited in our ability to be to lobby and be politically. No, it's not politically. Well, you know what I mean. Particularly at this time when we're expecting support for legislation going through. But we did publish a report in September of last year on supporting staff involved in investigations. One of the things that I was involved with in my last role at College of Physicians before I was here was the second victim phenomenon and the trauma of not just being involved in an event, but the trauma of then being involved in an investigation, and that can be devastating for some staff. You're absolutely right. Of course, staff well-being and patient safety are very closely linked. And if you look after your staff, they look after your patients well. So yeah, I enjoyed your piece in the HSJ.
Excellent. Well, the chat function is working. Frank has got that up and going. So do use it as we go along. And apologies for not having it up before. And thank you very much for fitting in, Frank, on the website. Our next speaker I'd like to introduce is Professor Tom Clutton-Brock. Tom has been a senior lecturer, then a reader, and now Professor of Anesthesia and Intensive Care Medicine at the University of Birmingham since 1990. He has maintained a long research interest in medical technology with particular interest in patient safety, and you will see when he presents his background, we'll have all sorts of monitoring equipment and etc. And he has done some work on point of care testing. He has also been involved with clinical devices as part of the Medicine and Health Care Products, the MHRA, which of course has been very prominent throughout the whole of this recent pandemic. Tom is also an associate medical director of the University Hospitals Birmingham, chair of the NICE's Interventional Procedures Advisory Committee, and a past master of the Council of the Royal College of Anaesthetists, where he chaired the Safe Anesthesia Liaison Group. Now, from October 2014, he was then interim and then deputy director of the Institute of Translational Medicine in Birmingham. He is currently director of the Medical Devices Testing and Evaluation Center and was named one of the 100 most influential drivers of health technology revolution globally. So it's a great pleasure to invite Professor Tom Clutton-Brock to present his paper today. Thank you.
Thank you very much indeed. What a very, very kind introduction. Let me just get my presentation up so that you can see that, I hope. And again, if you could just nod if my slides have appeared, that would be helpful. Yeah, thank you very much indeed. So yes, good afternoon, thank you very much indeed. So it's always slightly embarrassing when someone reads out the biography that you send, but that's a kind. In fact, I was presenting at a meeting last week when my colleagues from Birmingham just introduced me as the big bloke from Birmingham, which is a lot shorter really. But I have had a long career around that. So my clinical practice has been almost entirely in adult critical care with some anesthesia thrown in. I did step back from clinical practice in 2017 as a result of injuring my back. So I didn't take part last year clinically in adult critical care, but I will show you that some of the activities that we did get up to and things that we did. And you've mentioned some of the activities that I've had around patient safety. So I spent 12 years very part-time at the MHRA, still have good relationships with them, and I still feel that they have an important role. I think they're seen as the enemy and obstructed by many people, but I think used properly, then I think they do have an important role to play in patient safety. And yes, I was on the council at the Royal College and chaired the Safe Anaesthesia Liaison Group, which is where I actually came. I came as a member of CORESS, because CORESS has an anaesthesia representation from the college. And in fact, Frank, my lasting memory of the meeting, one of the meetings I came to, was a long list of things that people had taken out in the middle of the night, believing they were the appendix, and relatively few of them were. It was a rather worrying list of things that mainly junior surgeons had managed to remove, none of which I think were particularly dangerous, but there was an interesting list of things. And then more recently, because I've developed and largely now focus on my medical device and in vitro diagnostics interests, I run one of the NIHR-funded medtech cooperatives called MIX. There are 11 of them. They're designed to work with clinicians, patients, academics, and industry to bring new technology, and ours is focused around trauma, but not exclusively around that. And then 4 years ago, we had just over £7 million worth of European funding to build a specialized medical device testing and evaluation center. And I'll show you a little bit more about that. I sort of rather unashamedly advertise what we get up to, because we're very interested to get involved in new technology at a very early stage. There will be some overlap, I think, with the last talk about human factors, but this is very much around the pre-regulatory design and development of technology so that it's easier to use. I was a long-standing member of Interventional Procedures Advisory Committee at NICE, and I've been very privileged to chair it from 2016. And Frank was a very valued member as the vascular surgeon, and I'm very sorry that, well, I was going to say I'm sorry he was elected to council. Of course I'm not. I'm delighted he was elected to council at the Royal College of Surgeons, but it has meant that he doesn't have time to take part, and he's very missed on that committee. That committee looks at the majority of what we look at would be undertaken by surgeons. We don't look specifically at devices, but about 80% of what we look at does involve a device. And we issue a wide variety of guidance. And if those of you who have not been involved, because of the consultation phase, I would strongly ask you to have a look and see if we do issue guidance around something that you're involved in, that you get involved in the consultation, because it's that consultation that really allows us to get our advice tuned and to be useful both to clinicians and to patients. So medical devices. So they are absolutely ubiquitous. There are over 500,000 different types, not just devices, but different types of medical devices recognized in Europe. This is the old directive, which changed last week. But there are over 500,000 different types. And a lot of things that we use, I don't think we necessarily realize are medical devices. So a walking stick, a hearing aid, spectacles, for example, right up through to things that we clearly recognize that are, like surgical implants, pacemakers, and so on. And there is a regulatory system. I'm not going to go through it in huge detail because it is staggeringly boring, the detail of it, but it's an important one because there is legislation around how these devices, mainly around how they shall be marketed, but that legislation does run into also how they shall be used. So we are covered in medical devices, and the number and the complexity that we use are rising every year. So the top left of this slide shows that we're an aging population, as we know, and as we age, our reliance on medical devices just gets greater and greater and greater. Very few of us will finish our time on this planet without having something either replaced or paced. And the increasing amount of things that can be done are increasing exponentially. Below that is just a graph of the estimated spend, and you can see that it's a very rapid rise. It's one of the most rising expenses in healthcare. Medical technology does not exceed that of pharma. It's still about a third the cost of pharma, although was catching up, but actually pharma has cheated and just made itself even more expensive. And so pharma remains about 2.5 to 3 times the spend on medical devices. The big development in the last 5 or 10 years has been that of software as a medical device, particularly around artificial intelligence, and particularly around machine learning. So again, a surprise to many people, including me a few years ago, is that software on its own, so just a computer program, can itself be a medical device, and increasingly are regulated as such. Under the new regulations, which we have not moved to, then that software classification can be anything from a class 1 to a class 3 device. Currently, it's only class 1. And again, surgery is very well represented here. So robotics in surgery, I'll talk a little bit more in a minute. A lot of the robotics in surgery has an artificial intelligence component because you're trying to make something behave like a human, possibly think like a human, and also the machine learning component around it. A very hot topic, robotics. Expensive, not completely clear where it's going to fit, but it's an important topic. The bottom right picture really makes an important point, but perhaps not very clearly. That is, again, that the rise in spend on medical technology and devices in the UK is going up exponentially. But today we import about 75% of the devices that we use. We export close to 80% of the devices that we make. And you might say, well, that's silly. Why don't we just use the devices that we make? Somebody asked me that a couple of weeks ago. And I said, it was a young lady in the audience, and I said, well, do you mind if I ask you whether you drink whiskey or wine? And she asked a sort of strange question. And she said, well, I drink wine. She said, I can't stand whiskey. I said, well, this country imports 93% of the wine that it drinks. It's possibly slightly higher at the moment, 93% of the wine that it drinks. And it exports more than 99.5% of the whiskey that it makes. So unless you're prepared to switch from drinking whiskey to wine, then obviously we cannot use the devices that we make because they're not the ones that we want. But we are, and like everybody else, I can't help at some point to talk a little bit about the last 15 months or 16 months or so. We are unbelievably dependent on our overseas import of medical devices to keep our NHS and other healthcare services running. Just to put it in context, so our spend on medical devices is about the same in the UK as our spend on space. Now, you could argue that either way. My own view is we spend too much on space and not enough on medical devices, but they are both very expensive and very high investment areas. So I briefly mentioned robotics. I thought it was good to show a slide that wasn't just the Da Vinci. This is the Cambridge Medical Robotics, which has been in the press recently. It wasn't their fault, in all fairness. I mean, it was reported in Milton Keynes that this woman who had, I think, hysterectomy done with the CMR robot had much less post-operative pain. That was because she had it done laparoscopically, not because she had it done with a robot, but they made rather a lot of around that. And the intention here of this is to try and reduce the cost, particularly of single-use items in robotics. As many of you know that have used the Da Vinci robot, then the cost per procedure is not low. But again, finding evidence to come to committees like interventional procedures that shows that robotically performed surgery is better than conventionally performed surgery is difficult. It's not difficult to show, it's more expensive, but it's difficult. My personal view is that we will be rapidly using much more robotic surgery as time goes on, and it's time we learned around some of the faults and difficulties with it, and particularly around training people. But of course, devices are not without their faults. And these are the sort of three classic examples that everybody comes up, but there are many, many others. So the PIP implant, of course, was around a company that just broke the law. It wasn't actually, you could argue, it wasn't really a regulatory failure. It was really the fact that the company just didn't obey the regulations. So it's a little bit like saying if you're caught for speeding, the problem is the speed limit. It's not. The problem is you broke the speed limit. And so this company went out and bought silicon that was not of a medical grade and therefore ruptured. Similarly, the metal-on-metal hip. Now, there were some things that were badly handled in the metal-on-metal hip process, and I'm not going to go into those in great detail, but I think the fact that inflammation and potentially chromium getting into the tissues was not predicted at the time, and it took nearly 15 years for this to become apparent. And it's an important lesson in medical devices, including mesh, which I put at the top there, is that some of these problems occur after a significant period of time, particularly with implants. And therefore, in the current regulatory phase, it's unlikely that they will do a 15-year study before you get regulatory approval. But we also need a better system for knowing what we've put in people and what it's done to them. The bottom right is just a rather scary slide, really, about the increase in, and these are serious incidents associated with insulin pumps. And infusion pumps of all the medical devices that we use are the ones most associated with death. So across the world, infusion pump errors are still ridiculously common. And it's partly education, but it's also partly device design. So what are we going to do about making devices safer? Well, of course, the obvious thing to do is to have some regulations and say you will make your devices that meet a standard, that meet regulations. There's a policy for adoption. There's some legal force behind this. They're not optional. And so they sort of take the form of rules, really. And that indeed is sort of what happened. And the device regulations very much came out of the European Union, but it was really initially adopted technology and designs that was really based around having an open market rather than directly around safety. But if we just briefly review the history of device safety, then it really comes out of medicines, if I'm honest about it. And it starts in the 1960s, so Distaval is thalidomide, And it really was this extraordinary, unexpected effect of thalidomide. It was very widely used. It was an extremely popular and an extremely successful drug, but of course had these horrendous effects on the unborn baby. And that led to the medicines reporting system, which then led to a great rash of other medical device and in vitro diagnostics legislation across the world. So the FDA has its 510K, occasionally PMA process. We adopted CE marking. And there's a whole range of other regulatory systems out there. They're not dissimilar. And they basically say that essentially a device must be safe and it must do what it says on the tin. So the safety is the leading requirement for it. And then the second requirement around it is that it should do what it says it's going to do. There is now a third requirement, which I'll come to in a minute when I talk about usability of new technology. So that's where devices, the background of them was. And they've had an unintended consequence. So if we start with the figure at the top right, which basically shows the path of taking a new device from its original inception, from a university, clinician, research institute, over the hurdles of regulation. And many, many devices fail at that point. So many devices never get through the regulations. Having got through the regulations, there's then a much more complicated step in many ways. If you now have a device that may be sold, but that doesn't mean that people are going to buy it. It also doesn't mean that it basically has enough advantage over existing technology to be made and to be used. And to be critical of the NHS, I think we have a record of being poor at adopting new technology, irrespective of whether it's safe or not. And I think we are very good at hanging on to old-fashioned techniques and technologies because we're used to them, and we're somewhat suspect of new devices when they come around there. So there are two valleys of death, as they're called. The one is the regulatory step, and the second one is the implementation step of getting it from having been regulated into healthcare practice, be that the NHS or elsewhere. So a few scary figures. In Europe alone, there are 29,000 medical device companies in Europe alone. The average number of employees is 2. And roughly every 11 minutes of the working day, one of those companies goes bankrupt. It's an utterly broken system in Europe, and includes the UK, of trying to bring new technology into healthcare. And the only companies that really succeed at the moment are the large ones. So you have to decide, you either need to enable these companies in some way, or you have to say, stop having new companies, build some big ones, and try and make it more successful. I don't know the answer to that. I don't have the reference for the next statement, so I apologize about that, but it is quite widely quoted. It comes from the States, and it says that worldwide, if you look at surgical devices, now that's not very well, from swabs through to robots, with regulatory approval, so this is not the regulatory step, they've got through that step, then less than 1% of those devices make it to clinical use. So there is a massive wastage of new development of new technology that is never, ever used. And part of that is because we don't want it, part of it's because it's difficult to use, part of it's because it's expensive, and part of it's very difficult to get the evidence that this is better than what we currently have. It costs £1 billion to bring a new medicine to market. £1 billion over a 10-year period to bring a new medicine to market. The costs of medical device approvals are going up and up and up, and it's not uncommon for us to see the total sum being somewhere between 10 and 30 million pounds to bring a relatively straightforward medical device from idea through into healthcare. So we can't escape really with two things that happened last year, and both of those have been mentioned. So clearly we left the European Union, and the current position, which is likely to change, is that we're going to move from CE marking in England, Wales and Scotland, but not in Northern Ireland, to a process of UK CA approval. We will continue with our device regulations, which are 2002, and not move to the MDR, which was enforced on the 26th of May. We will have authorized, not notified bodies. So if you want to sell it in the UK and EU, at the moment, you have to have 2 sets of costs of getting your approvals. What I do support is the increased requirement for usability, which I'm going to talk about in a minute, increased requirement for clinical evidence before things are adopted. Previously, 80% of medical devices got onto the market never having been used in patients through the clinical, through the equivalence route. Some will still do that, but I do think that was wrong. And also a massive increase in post-market surveillance, which is where things like metal-on-metal hips and mesh, and even to some extent PIP implants would have been picked up. Difficult not to mention COVID. It's obviously touched all of our lives in very different ways. PPE was on the BBC again this morning. The BMA and other groups, the nursing groups, have got together to say that the current recommendations from the DHSC about wearing surgical face masks to protect yourself are just inadequate. They defend themselves, saying it's based on clinical evidence. Surgical face masks are designed to protect the patient, not to protect you. So this young lady is wearing an FFP3 mask, but because of where the valve is fitted, she's at risk of infecting patients. So you can't wear this in theatre. There are pictures of Joe Biden wearing 2 masks. There are a whole range of pictures of people wearing different masks. She is wearing a face shield, which does reduce that. I'm going to talk a tiny bit about ventilators. I can't really avoid doing that. I had nothing to do with vaccines apart from receiving it. But what I have had a bit to do with is the repair and prepare agenda. And so that picture there is an aerospace manufacturing plant in the UK in January of this year, and it's empty. So the bottom has completely fallen out of much of our manufacturing industry because of the fact that nobody is buying that technology. 16th of March 2020, Boris Johnson announced the ventilator challenge, said that we needed initially 90,000, then it got dropped to 50,000, then it got dropped to 30,000 new ventilators, and we had about 6,000. And there was a massive response from the UK industry in terms of producing these. I'm going to show you a picture. I probably shouldn't. You're one of the very few groups of people who've ever seen all of them put together. This is 13 of the 14 ventilators that were put in for the challenge. We tested 13 of 14. There's one we didn't test, and there's one that's not in this image. And this was just an extraordinary collection of the technology that British industry came up with to try and solve the ventilator issue. Only one of those, the top right, the Penel-ESO 2, actually has got through. What was important was, because of the urgency around this, was that there was a relaxation of the medical device regulations under derogation, which allowed these devices potentially to come through to be used in a pandemic situation, but not to be used regularly. There was some that we didn't get, which I think is probably quite a good thing, and sort of things like this. There were some truly bonkers designs that people came up with. None of these really arrived with us. All of the 12 of the 14 that came to us could have been used in an emergency. But what was very clear was they were quite unlike anything anybody had ever used before. And so training people to use them was going to be absolutely key. So when I was at the MHRA, and this is a few years ago, but it hasn't changed, we analysed the causes of the adverse incidents that have been reported to us. There's a big adverse incident database. In only a third of those did the device actually fail. And modern medical devices are remarkably good. Very few of them go wrong. They do, of course they do, and they do fail. But at least a third and probably 2/3 of the errors, and exactly those as described in the first excellent talk, are around the fact that we make human errors and we don't use them very well. And therefore, that does seem to be an obvious point in patient safety, is to try and address the usability around medical devices, be they simple or complex. Now, training is, of course, an important component in that, and I don't for a minute want to undo that, but we don't make devices that are easy to use. Any of you could get into a production car and drive it. Okay, because the pedals are in the same place. The wheels go the same way when you turn the steering wheel, not the same in medical devices. And so there's massive evidence to show we need to improve this. And the regulators have picked this up, and both the FDA and the MHRA issued guidance around usability testing, and there's an ISO standard around it. And the rules are you should use real users, which seems sensible, in a realistic environment, but not on real patients. And for us, the difficult environments to borrow, we used to be able to, were operating theatres, intensive care units, emergency departments, and ambulances. And so with that money from Europe, we built a simulation suite. Now, when I first showed my background, someone quite rightly said, oh, you're sat in a clinical simulation suite. I am sat in a simulation suite, but I'm not sat in a clinical training simulation suite. I'm sat in a medical device testing simulation suite. And our operating theatre, our ambulance, our intensive care units, all the rest of it are solely used for testing usability of medical devices in a realistic environment on very expensive plastic patients, pre-regulatory approval. We had to make some adjustments. So here's one who kindly donated the contents of his chest to science, and he's been set up for testing CPAP systems, which again have become of great interest, particularly in terms of the amount of oxygen that they use. He, when he was new, was just over £100,000. The box sat on the trolley to his right is £60,000. Between him, he does breathe and he does cough and he does some other useful things. So it's not a cheap game. I also want to end with just a couple of slides and just walk you through very briefly a process that I believe is important. I think it's easy to forget that failure to innovate is also a patient safety issue. And therefore, the concept of regulations to me and many other processes is actually to make sure that we innovate safely, not to try and block innovation. Quite right to block unsafe innovation, But again, to repeat it as an obvious point, but one I think that is sometimes forgotten, is that failure to innovate is also a patient safety issue. So I'm very briefly in 2 slides just going to walk through, I know they seem complicated, but they do start at the left and go to the right. Just a little bit of the process to give you some idea how important it is for clinicians in all specialties, and particularly in surgery, to understand how that process is so they can understand where they need the interactions with it. So someone comes up with an idea, that may be you, it may be industry, it may be someone in university. They will usually register some intellectual property around it. It needs to meet an unmet clinical need. The NIH are extremely common on this. And it needs an outline value proposition. If we did this, would it save money? Would it be neutral? Would it be better and then more expensive? And also, who's going to pay for it? We then sit as an organization in MD Tech. We then speak to people at this stage. So we like to speak to clinicians in particular very, very early on. So many people have spent a large sum of money and got nowhere because they don't really understand the process. We'll discuss the regulatory path. We'll get patients involved. We'll have you involved to come and look at technology and try it in a realistic environment. We'll think about how it's going to be made, look about who's going to fund it, and then we will make a decision we're going to support it or not. Then there's a whole pile of regulations and testing and other things, and I'm not going to go through these in huge amounts of detail, but the main ones about electrical safety, the usability standard is there, and then there are some device-specific ones, so these are specific to ventilators, but there are loads of specific ones to different types of technology. You then go through, basically, you then most of the time now, you'll be doing a clinical investigation, which again has rules. You need the usual approvals and a clinical investigation plan. You need a special thing called a letter of no objection from the MHRA, which is quite a complex process before you can undertake a study in a non-CE marked device. At the end of that, you get the big hurdle of UK CA marking, CE marking, 510K approval. One area we're very bad at is actually looking to see whether we can use things in real life. And so our devices come through, they get CA marked, CE marked, UK CA marked. In North America, it used to be if you were a surgeon and you wanted it, you bought it and you charged your patients. Here is a complex procurement phase to go through. I'm not completely clear how that works. And there is, I think, a very large unmet need to run proper service evaluation studies in the NHS that looks at new technology, almost in a sort of research type way, and publish its results. And I think that stage is missing. So we miss that stage. So a nice IPAC, for example, very seldom gets information from that stage. It often waits for much later, much more expensive randomized controlled studies. And I think it's a shame that we don't get that information. We only use peer-reviewed publications, so it's important that it goes out to the press. When you come to NICE, is it worth coming to NICE eventually? Yes, NICE recommendations are valued worldwide. If you get a medical technology briefing, it comes with a mandate for funding now, as of this year. And then you come to interventional procedures, medical technology guidance, very occasionally technology appraisal. Of course, ultimately, you want it as part of a clinical guideline. And then finally, you're making success, you're finally making money, and then finally, you're into the post-market surveillance and the adverse incident reporting. I want to finish there. It was a bit of a run through a little bit. You can see that I'm fairly passionate about the fact that we need new technology in healthcare. We need new technology in surgery. I think we need to work with the regulators to make sure that the improvements that we have are safe. I think we need to understand that there is a need for training. Of course there is. But there's also a need to insist that manufacturers make technology that we can actually use. And ultimately, I think the outcome from that is improved patient safety. Thank you very much indeed.
Well, Tom, that was a fantastic presentation. I really enjoyed it. And one standout figure for me was that 29,000 medtech companies in Europe alone. But even more interesting, that the average employees were only about 2. I remember going on a surgical trip to India and watching young boys of about 10 to 12 cross-legged on the floor, making surgical instruments, scalpel, forceps, etc. And that was the time when we had the major hepatitis B problem in the UK. And so we had moved to single-use instruments. And one wonders where the level of quality assurance comes when you get companies sending stuff to the UK for use here.
So that is where the whole business of CE marking and everything else is supposed to cut in. And I think overall, I think it's probably true to say that to a reasonable extent it does. It's certainly better than having nothing. But you are right that there is a need to improve that quality assurance. So medical devices are usually manufactured under ISO 13485 assurance. But you're right. I mean, and certainly my experience is not so much in surgical instruments, although I was involved in the whole business over tonsillectomies with single-use instruments. And also been involved in issuing the guidance about CJD and reusable instruments, et cetera, recently. But certainly if you look at the ventilators that we imported from China, because that was the third wave really of the government approach was to import very large numbers. They do sort of meet the regulations, but they're pretty shabby. So I think if you say to me, can you meet the regulations and still be pretty shabby? The answer is yes. And I think that is absolutely why we need this real world exposure to say it is a pair of scissors, it looks like a pair of scissors, but you know what, it doesn't cut. I know that's rather basically put, but I mean, that would be my sort of approach around it already.
Very well put. Frank, do you want to pick up on the questions that are coming through?
I have got one question, and it's from Mike Roddis. I think just opening it out a bit. Artificial intelligence is very much in the news this week in terms of defence, and I know there are a big budget in terms of defence. Tom, do you see any role for that in the future? Mike, being a pathologist, has asked whether there should be software which observes the surgeon to see if their behaviour changes, alerting to the possibility of an error. He probably has less worries about Big Brother than some of the surgeons do. But just generally, do you have any ideas about incorporation of artificial?
Yes, I mean, without a shadow of doubt. I mean, I think there's a lot of misconception about what artificial intelligence actually is, and a lot of the stuff that we see actually has sophisticated algorithms in, but are not actually intended to act or work in a way that a human would. But I think there are elements around that. I think there's quite a lot of interest actually even in sort of wearable monitoring amongst surgeons to show that they're getting tired and they're getting this and that. I suppose, Frank, you and I probably relied on the fact that the nursing staff would make some rude comment if they thought you were doing something stupid. But I think that there is an interest in that. We've just finished a project in tracking where you are in the operating theatre. You wear a little device on your shoulder, rather nicely called a parrot. And it's tracked. It sends out an infrared signal and it's tracked. Now, why do you want to do that? Is it so I can remind you and show you the statistic of how often you're late at the start of a list? No, it's done to show whether, it's done to show whether or not you've been in the area of risk or zone of risk or not. And I think there is some interest around that. So yes, I think that's right. I think that there is the possibility of recording the movements of a very skilled surgeon's hands and then repeating those. I think there is new technology coming along that will actually show you that there's a blood vessel under the tissue that you're going to cut rather than finding out the usual way. And I think there are all sorts of things like imaging around the margins of tumors. I think there is an absolutely massive wealth of stuff that's potentially out there. And I just think we have to understand how we adopt it safely.
Thank you very much, Tom, and a very erudite and as ever entertaining talk. Thank you. Back to you, Bernie.
Right, thank you very much. If there aren't any others, we'll move on. Mr. Jerard Ross is going to talk to us. He's actually asked the question already, but he's a member, a medical legal advisor to the MDU, and I declare an interest because I used to be with the MDU. They served me pretty well. They needed to, I think. Jerard graduated from the University of Aberdeen in 1994. He moved into surgical training in Edinburgh before completing his MD at the University of Manchester. He then joined the MDU and he was a consultant in adult and pediatric neurosurgery in Edinburgh. He was also a surgeon to the Scottish National Pediatric Epilepsy Programme. So he brings to the MDU a real wealth of surgical experience to support the work that they do. And I think those of us who have had to make the use of the MDU in legal terms have always been grateful for the support they have. And I think that comes from the knowledge that so many of their advisors and experts have. So over to you, Jerard, for your presentation. Thank you.
Thank you very much. I hope that you can see my screen. Could somebody give me a thumbs up to let me know? Thank you very much. Well, thank you, ladies and gentlemen, Professor Smith, Lord Ribeiro and CORESS for asking me to come along and talk to you. Thank you for inviting me to talk to such an august audience and share the virtual stage with such luminaries of the surgical field, the anaesthetic field, and national figures in patient safety. Just in case there's any doubt at all, I'm neither of those things. I'm not a luminary in any field, but I do have to admit, as you've heard, that in a former life, I was a consultant neurosurgeon. I joined the MDU about 8 years ago, relinquishing all clinical work finally last year. My job nowadays is to look after doctors when things go wrong in their clinical practice. And that's the point of this talk today, is to share some observations with you about how to manage things right when the inevitable happens in your clinical practice and an outcome of a clinical interaction is less than ideal. I think that what's just struck me in looking around this audience today is the fact that you are here listening to these people talk and listening, hopefully, to me as well, is that you're probably self-selecting into being perhaps in a safer cohort of people. So to some of you, many of the observations you're going to hear are going to be well worn, and I apologize if this information you've heard previously. I do have to be honest, though, that when I speak to doctors on a daily basis, and that includes surgeons, and when I advise surgeons, a lot of the homilies, if you will, that I'm going to give you today are not well understood, and sometimes that impacts negatively on them, and sometimes exceedingly negatively. So for clarity, as an aside, any scenarios that I mentioned today are based only very loosely on cases of which I'm aware. Confidentiality is something of which we're always exceedingly conscious. And another thing, any of the processes I mentioned today, they're going to be focused particularly on England, to a lesser extent Wales. The processes in Scotland and Northern Ireland are slightly different. The general principles of what I'm going to say, though, are applicable, I think, across all the jurisdictions in the UK. As most of you will know, I hope the MDU is a non-profit mutual organisation to defend doctors. So we're not specifically a safety organisation, although obviously we come across issues where patients have been harmed, and we do contribute to the national surveys and national issues that arise. We take about 30,000 calls a year, and about half that number of new files are opened annually by our members, and we encounter lots of doctors who suffer both acute and chronic sequelae arising from serious patient safety incidents. We also interact with a number of the bodies that will investigate these sorts of investigations. Let's talk about very briefly a scenario, and again, I apologize if this is slightly out of date. I've got to be careful in terms of the scenarios I choose. Right-sided colonic cancer diagnosed in endoscopy, an open hemicolectomy, an inadvertent injury to a renal tumour with monopolar diathermy, severe post-operative intraperitoneal hemorrhage some hours later, managed by a colleague who happened to be the clinical director. All done out of hours, and the patient developed a post-operative myocardial infarction and died some weeks later after lingering in the intensive care unit for some time. So whilst the individual scenario itself is obviously quite specific, one can see how that one clinical incident could develop. And I think this is one of the issues that I became more aware of when I started with the MDU, and was probably to some extent blithely unaware, or at least not as aware as I should have been as a consultant surgeon, and certainly as a trainee. When things go wrong, lots of things can happen, and lots of things can happen at the same time. We spend a lot of time worrying about civil claims and negligence, but of course claims and negligence, if you're in the NHS, are handled by the NHS Litigation Authority or similar in Scotland. But things like NHS complaints, GMC investigations, coroner's investigations, all of these things can go on at the same time and result in doctors having to deal with lots of different requests for information, for lots of different problems and questions about their training and ability coming into rather acute focus. So how do we approach that? There are some things that we see regularly, and I apologize for trying to get the onomatopoeia in here and getting lots of D's in, but it seemed right. We still see doctors trying to deny that something has gone wrong. In this case, when I've mentioned, it might be very obvious that something has gone wrong because the The assistant might have noticed it, the staff nurse in theatre may have noticed it, the operating surgeon who came back in to tidy up later that night might have noted it. But still we have doctors who will deny that something has gone wrong in the face of often quite significant evidence to the contrary. The worst thing is actually lying or dissembling when you know that something went wrong, but refusing to admit it and saying that nothing went wrong. We do have the situation where doctors will, in one forum of investigation, say that nothing went wrong, but somewhere else admit that there was a problem or something inadvertent had happened. And when that occurs, obviously doctors are putting themselves at risk of their honesty and probity being taken, being questioned, and that's really very serious when it comes to the GMC. Deflection is another common issue. I didn't do anything wrong, it was the registrar, or it was the anaesthetist, and that's a common one as well. Or worse, deflection of the problem by suggesting that the fault lies with the blinkered approach of the person investigating the matter rather than with them. Statements about, why am I being investigated when you didn't speak to Miss Y when she made a mess of procedure X? Unfortunately, these sort of statements are still quite common, and although they may be accurate, they're unlikely to be helpful. Diminishing issues, this sort of thing happens, it's no big deal. You can't expect me to take on difficult cases and then be unhappy when the odd case doesn't work out well. Again, we all know that complications occur and things sometimes don't go to plan. Suggesting that there isn't a major issue, or at least not being prepared to consider it, is a real problem for doctors, and particularly for that patient and their grieving family if the patient has died. Surprisingly, indignation or disdain, I had to try and get that D in somewhere, being investigated are surprisingly common as well, perhaps more commonly in more junior doctors, but we do see it. It's amazing how many people will tell me that they're world-renowned or nationally recognized for their work, or they're all leading experts, and sometimes that's absolutely true. Although at times it might be refreshing to have somebody say that they are pretty average at what they do, which statistically speaking must be true for many of us. In all seriousness though, all of these things detract from your response and how you might be viewed by your employing organization or one that grants you practicing privileges. The maintenance of professional relationships is really important. One of my ex-colleagues published an article in the BMJ some years ago now. He also ran NCAS for many years. And that article was called The Savvy Doctor, and it's one that I think of quite often. I'm sure I wasn't very savvy as a consultant, but I mention this to doctors who I have to help. The savvy doctor recognizes that, uncomfortable as it may be at the time, over the course of a career, concerns are likely to be expressed about how you practice. And most of those issues are unlikely to be career-threatening unless they're handled in ways that compound the issues. From the professional perspective, and many of you will be in that managerial phase of your career, a doctor who responds well to concerns by saying, well, I can see why you would be worried about this. I want to help you investigate it so we can either dismiss this or resolve it, is behaving impeccably and immediately enhances their credibility and their position for ensuing discussions. So that's something I come back to quite often when I speak to doctors after something has gone wrong. So when things do go wrong, what does getting it right look like for the clinician? Well, it's important that they receive appropriate support. And whilst the well-being of patients is always central to our decision-making as doctors, doctors, as we've heard, can become the second casualty of a situation. Healthcare providers involved in an adverse incident commonly suffer severe psychological and professional sequelae, and clinicians coping with the aftermath of an adverse event might well be likely to make a subsequent error. One of the most common questions I'm asked is, well, what happens next? And as outlined in the Supporting Surgeons After Adverse Events document from the Royal College of Surgeons in England in 2020, there is a lack of knowledge, I think, about what processes should be followed after an adverse event. Timelines can be very vague, emotional and practical support for affected surgeons may be exceedingly limited, and there's little guidance for those who do wish to provide that support. Too often, existing responses focus on statutory responsibilities of investigations, disciplinary processes, and too rarely on the well-being of the surgeon or technician involved. And there's no clarity around whether the surgeon should be able to continue to work or not, and how the surgeon's return to work should be supported. The surgeon themselves might be faced with personal or professional challenges, talking to the family, talking to their colleagues, the emotional impacts around that, concerns about their reputation, loss of confidence, fear of litigation, fear of the regulator, and concerns over the ramifications of the case. In short, doctors and surgeons need support, but accessing it can be really difficult. As a consultant, I would often speak to a trusted senior or peer, but many people, as they get more senior, find that those people just aren't around, and everybody is coming to them with their concerns and difficulties, and there's nobody around to support them. The primary focus of the organisation will be on patient safety, but the concept of the first responder is one which is gaining some traction. It's something that I will come back to. Every trust and health board will have occupational health services, and they're an important source of confidential support for doctors. And outside the organisation, general practitioners can be really helpful. Defence organisations are, in my opinion, very important. If at times, sometimes underused, I think particularly by consultants. GPs are much better at getting in contact. In our experience, consultants will often leave it much later before they get in contact, expecting that the trust or their employers will sort out. We're not just there for litigation. We support doctors daily through issues, and having somebody who understands what's happened and can be talked to confidentially, I think is one of the most important things that we do. We are, after all, doctors for doctors, and when you call the MDU, you will speak to a doctor. Listening to the impacts of cases on doctors is humbling, but it does also allow us to act as a sense check for members. Distressed doctors often assume that things are true. They say things like, they all think I'm useless, without any evidence, of course, in support. Gently pointing out those assumptions can be helpful for members. Similarly, gently indicating when someone is not being reasonable in their approach, be that a member or their line manager, often helps add some perspective. In the MDU, we've got a peer support program that can put doctors in touch with others who've been through the processes that they're facing. And the practitioner health program of NHS England is another example of an NHS-funded program for doctors with mental health and addiction problems, another source of support for doctors historically underused by surgeons. There is one issue that I wanted to touch on because I think it's really important for our members, and it's one of the reasons that I think that doctors who have an unexpected death, for instance, should be in contact with their defence organisations. Gross negligence manslaughter is one of those charges that it's just vital that doctors have a low threshold for contacting us when they think something may go down a criminal route, and certainly when it does. As you all know, gross negligence manslaughter is a common law offence. It's considered when the death is a result of a grossly negligent, though otherwise lawful act, or omission on the part of the defendant. The law was stated in Adamaco. I'm not going to rehearse that now, but it didn't really provide a model which could be adopted by a judge in describing that concept as a part of a direction for a jury. This was addressed to some extent in a couple of independent reports, and I'll quote from the Williams review of it now, which said, despite reports to the contrary, investigations of gross negligence manslaughter in healthcare are unusual, prosecutions are rarer, and guilty judgments are rarer still. And that chimes exactly with my experience as supporting doctors who are being investigated for gross negligence manslaughter, the vast majority will drop off. The report goes on to say, though, there is no doubt, however, that recent cases have led to an increased sense of fear and trepidation, creating great unease within healthcare professions. This has been compounded by a perceived arbitrariness and inconsistency in the investigation and subsequent prosecution of gross negligence manslaughter. Typified, I think, by the case of Selu, who I've had the honour of hearing talking about his experiences, as many of you will. The direction given to the jury in Mr. Selu's case was quite frankly insufficient. The MDU's view is that the law as it stands today, so not 2016 but 2021, is better than it has been in recent times in terms of providing clarity about how a jury should be directed. However, the problem for doctors is not just the courts, but very much with the procedures that are used prior to a decision about prosecution. And there's such a high number of cases that never get to charging that the wrong cases are being investigated. So most cases are referred to the police by coroners, and of course it's right that coroners don't hold inquests when it might interfere with a right to trial, but there's a 95% non-prosecution rate, which is obviously far too high. And we've suggested that they should be channeling cases through the chief coroner. Investigations can take anywhere between 6 months and 3 years. My last one is still ongoing and has taken over 2 years as it stands. And in that time, doctors are often restricted from their work. In addition, the GMC will refer doctors to an IOT within that interim orders tribunal within that period, which invariably imposes restrictions on doctors. And whilst prosecuting the right cases requires a proper understanding of medical causation, one of the difficulties is getting the right experts with a common understanding of the law, which is clearly explained to experts. And that's one of the roles that we are particularly good at within the MDU. We have an in-house legal department who are very hot on gross negligence manslaughter and talk to national panels about it. So I've kind of diverted slightly. This is one of the really big reasons that I think surgeons, when they have an unexpected serious outcome, should contact us, is to make sure that this problem is avoided as far as possible and certainly managed actively if it becomes real and live. Personal reflection and learning is another part of engaging with things when they go forward. Again, I'm sure you're all very reflective practitioners. The fact that you hear means that you think about patient safety. There's good guidance out there for doctors and medical students on reflection. I still refer to it, if not on a daily basis, there's certainly on a weekly basis, and ask doctors to look at it. There are some useful quotes in it, because still to this day, doctors tell me that they don't reflect. I had a journey with a consultant surgeon before the pandemic, and he told me that he told his juniors not to write reflective notes. I think because of the Bawa-Garba case. And there's useful quotes in the reflective practitioner guidance. You know, it should be rare for a reflective note to contain factual details that have not been recorded elsewhere. Everything that happened is going to be in your statement. You're not going to be putting things in your reflection that you haven't put in your statement. You might put learning points in your reflection, but you're not going to be rehearsing different facts in your reflection. They're not subject to legal privilege. It is absolutely true that a court can require their release. But again, if there's nothing in your reflection that's not elsewhere, it's not going to be a problem. The GMC doesn't ask doctors to provide their reflective notes in order to investigate a concern about them. In fact, it's the opposite thing. I'm often asking doctors to actively reflect, give them to me so we can share them with the GMC to reassure them about what the doctor has done as a result. And as I'll come back to at the end, evidence of insight and remediation, such as reflection, may reduce the need to for the GMC to take action. Touching on Bawa-Garba, and I have to be clear that Dr. Bawa-Garba was not an MDU member. The MPS released a statement around the use of her portfolio evidence in the case. And I think the important quote is, at no time during Dr. Bawa-Garba's criminal trial was her e-portfolio reflection statement presented to the court or used as evidence. This is the MPS and her barrister. I'm sure you all know how to write a reflective note. Worth having a look at the guidance on the GMC website, and worth doing before the problem becomes bigger. So as soon as you're able to reasonably reflect on something, get some reflection down, even if nothing happens as a result of the case. I know we're under pressure of time, so I'll quickly move on to the duties of candour. I know this is something, again, that you will be aware of, and there are two duties of candour that we talk about now, the professional duty of candour being the first, and this is something that's been around for a long time and is within good medical practice. You must be open and honest with patients. If things go wrong, if a patient under your care has suffered harm, distress, you have to put matters right if possible, offer an apology, and explain fully and promptly what has happened and the likely short-term and long-term effects. So the hurdle for the professional duty of candour is low. So when something goes wrong, however minor, it's appropriate to be discussing that. Whether or not it's appropriate discussing your misses is a slightly different question, but professional duty of candour is what you should be doing whenever anything goes wrong. There is, of course, the secondary care statutory duty of candour, and this is in England. The Scottish duty is slightly different, although in effect very similar. Any unintended or unexpected incident that occurred in respect of a service user that could result in or appears to have resulted in the death of the service user, severe harm, moderate harm, or prolonged psychological harm to the service user. I'm not going to dwell on that. The important things for the organisation to do, or you as a representative, might be to tell the patient, give a full explanation, and provide an apology, and keep a written record of the notification of the patient. So the hurdle to engaging the duty is low for the ethical duty, it's high for the statutory duty, but the outcome is the same thing, that you tell the patient about what's happened. Moving on again, one of the other things that's really important is engagement with the organisation when something does go wrong. And I would recommend contacting your defence organisation if something does, because of that issue of multiple jeopardy. It might be in non-clinical issues you're asked to contact your healthcare union, be that the BMA or the HCSA. We may ask you to speak to them as well if it's to do with conduct, but certainly if it's to do with a clinical matter that's gone wrong, get in contact with your defence organisation. Put together a detailed account from the records. It sounds obvious. It's amazing how many people will put together accounts from memory, or who will make comments without having access to the records. Don't produce anything without having access to the records, and an incorrect statement produced in distress can well end up with the police or the GMC. These things are all disclosable if it mentions the patient by name. The other reason for contacting your defence organisation is, of course, that your trusts may be very helpful in management of a serious untoward incident, but they're not going to help with police interviews. They are not going to assist with GMC processes. It may in fact be that they're contributing to the GMC processes about you should the GMC become involved. The trust usually help when it comes to inquests, but not always, because there may be a conflict of interest. So yet surgeons in our polling often have not been great at involving their MDO because they expect their trust to do things. And most of the time that's true, but there will be a number of circumstances when they don't, and those can be quite serious circumstances. As you all know, the organisation's response is about information gathering around the serious incident framework, and that describes the process and procedures to ensure serious incidents are identified correctly, investigated thoroughly, and learn from to prevent the likelihood of similar incidents happening again. That's how it's described. It was published in 2015. It's still in use in most places in England, although it is in the process of being updated. The pandemic moved that back. In fact, there is an updated version in place for early adopters. And again, we would expect an organisational response to involve that pastoral support. And one of the things that came out of supporting surgeons after adverse events was the importance of leadership in senior doctors, which many of you obviously are. So when things go wrong with a junior colleague or even peers, it's important to set the tone of what happens, to be supportive, to avoid blame, to reflect on how adverse events happen to everybody, because we all know that they do. And these softer skills can make quite a difference to a distressed surgeon who's really worried about the consequences of what's just happened, and who probably doesn't need the extra layer of comments or an unsupportive management team. The organisational culture is, I think, one of the things that we're particularly aware of, and it's nice to hear Kevin talking about it. The introductory version of the Patient Safety Incident Response Framework, which is the new SI framework, does have a section on just culture, something that Kevin mentioned. It recognises that most incidents are caused by weaknesses in systems, which lead to conditions that make it difficult for individuals to do the right thing. And organisations are urged in that to consider how they guard against bias in their investigations. Staff involved in similar actions or decisions leading to a patient safety incident should be treated in the same way, irrespective of whether the patient was or was not harmed and the grade or the professional group involved in the issue. There's also a risk of discrimination, and I think it's something which we are aware of within the MDU, and I think is becoming more widely known within the health service. It's important that organisations ensure that individuals making decisions are up to date in terms of equality and diversity training and aware of the risks of unconscious bias. The just culture approach, as well as featuring the early adopters, has come into other aspects of health service publications, and there's a really good stepwise approach set out in the Just Culture Guide about how to approach something going wrong, looking at the deliberateness or willfulness of an action, the health of that individual, the foreseeability of the event and how that links into past training and protocols, whether professional peers would have acted in a similar way, and whether there are any mitigating circumstances. Finally, there's the issue of reporting externally, and I won't go into this, but there's a national reporting and learning system, yellow card scheme we've heard about, MHRA, CORESS as well, and and the healthcare regulators, of course. And I think that's where what I want to focus on for the last part of the talk is the healthcare regulators, because I didn't really talk about it, but all of these things can engage with the GMC, and the civil claim issue was what I was worried about as a junior, but in reality I should have been much more concerned about GMC investigations, because they are the body who can remove the ability for you as a clinician to work. Their overall objective is to protect the public. They're not there to protect doctors. They're there to promote health, safety and well-being of the public, to promote public confidence in the medical profession, and to maintain proper professional standards. The reason I mentioned insight at the start of this, in terms of the remediation and reflection, was that it is well known from the GMC's own studies that demonstrating insight early, and I'll go on to what that means, in GMC processes is hugely beneficial. We know that doctors who don't demonstrate that have a much higher risk of having action taken on their registration. In fact, the sanctions guidance to the NPTS, which is the tribunal aspect of the GMC, although functionally separate, explains that insight involves demonstrating reflection and remediation, accepting perhaps they should have behaved differently, showing empathy and understanding really important things. Taking timely steps to remediate and apologise at an early stage. So getting an apology in at the start, thinking about things, reflecting, discussing, doing these things before it becomes an issue is protective should it get to the GMC. That's the sort of information that I would share with the GMC early on. And demonstrating the timely development of insight during investigation and hearing should that not have happened earlier. Remediation is where a doctor addresses concerns about their knowledge, skills, conduct or behaviour and takes lots of forms. I'm almost finished now. So in terms of protecting yourself before things go wrong, it's really important from our point of view that you evidence your practice. Your appraisers will want this too. If there's an opportunity for you to gather evidence about your practice prospectively, take it. If there are national audits to which you can contribute, do so and record the information for your appraisal. If you're engaged in this independent practice, if you're engaged in independent practice, do the same, gauge outcomes and satisfaction with what you do. When things are going wrong, this is perhaps aimed at more junior people, stop and think. Do I know what I'm doing? You have to work within your competence. Could I be wrong in my approach? Have things moved on? And that's something I see with more senior doctors. When things go wrong, is an inability to accept that things are not the same as they were 20 years ago. And sometimes when you're very senior, people won't tell you that things are different. I always used to wonder what my most influential mentors would say about a particular situation, and asking that question of yourself is often helpful. Things will go wrong, okay? When it does go wrong, try not to make it worse by how you react to the circumstance. Involve your defence organisation, involve your colleagues. Be careful with your correspondence. Remember, it's all disclosable, and be aware, I'm sorry, the word practice is in there. Be aware that everything you write that refers to the patient can get to the patient or their family. So final thoughts on healthcare, as you know, is not risk-free. Mistakes happen. Even single clinical incidents can lead to a myriad of medical legal consequences. And second victim literature still should bring us to think about the stress caused to the individual. Organizational culture is one of the key solutions to mitigating the second victim effect, and a just and learning culture should be the aim of every NHS and independent healthcare organisation in the UK. Thank you very much.
Well, thank you very much indeed for that, Jerard. A very comprehensive coverage. I have to say, as you spoke, gross negligence, manslaughter, and David Selous came very close to my mind.
Yeah.
You will know that there were many surgeons who felt that a miscarriage of justice had taken place. The prosecuting medical witness was uncompromising in his accusations and subsequently became somewhat of a medical surgical pariah after the case was reviewed. There were several people in the House of Lords on the legal side, Lord Mackay of Clashfern, Lord Wolfe, and others who provided evidence and support for Sir Norman Williams and a campaign to try and move Selous from a high security prison to an ordinary prison. So, you know, we're discussing people who go up before the GMC and may get a slap on the wrist and may get admonition. But when it actually involves a prison sentence, that is a major, major change to anybody's practice. And I'm quite sure that the time that Selous, he had a 2.5-year sentence reduced, but I'm sure the time he spent in prison will have scarred him for life. But thank you very much for your presentation today. Any questions on the chat, Frank?
Just a comment really from Kevin Stewart, who kindly, while this was going on, and opposite to Gerard's last slide about the second victim, Kevin says that the secondvictim.co.uk was established by the Yorks and Humber Health Services to provide resources for clinicians who are suffering psychologically after an adverse event or any investigation or legal process. So if Gerard's talk has touched a chord with anybody in the audience, you certainly don't have to share it, but there are resources available to you to help you with any consequences you may be suffering from that event. So I'll just hand back to you, Chairman. Thank you.
Yes, and before I go, just to say, one of the things you said there struck a chord, getting it right when things go wrong. An ex-registrar of mine, Tim Briggs, produced a report, Getting It Right First Time, and I thought those two things chimed very well. Thank you. Now, for our last presenter, but not least, is one Professor Peter Brennan, known to many, many of you. And in fact, the slide he's just put on means I don't have to say half of it because it's all there. But Peter, apart from anything else, has held a personal chair in surgery, and his research efforts are enormous and what he's achieved. He was the youngest president of the British Association Oro-Maxillofacial Surgeons. And when he invited me down to Brighton to give a talk, he was merciless in his comments and critique and made everybody laugh. He is a bit of a joker, I know, but actually that hides his huge contribution. A former chairman of the English College of Surgeons MRCS Court of Examiners, and now intercollegiate chairman of the MRCS and the DOMS exam, which is of course responsible to all 4 surgical colleges and the GMC for the standards and quality assurance of those examinations throughout the British Isles. He's currently editor-in-chief of the Journal of Oral and Pathology and Medicine, and he's a strong advocate for providing the highest level of care for patients. And his work on human factors, which he will tell us about, has been groundbreaking. And I hope we will hear more about this afternoon. So if I can invite you, Peter, to take the floor, I'd be most grateful. Thank you.
Thank you very much, Bernie. And in fact, the first time I met Lord Ribeiro in his robes was about 5 o'clock in the morning down in Brighton when I was the president of BOMS, and there was a fire alarm. So it was actually his bathrobes rather than the House of Lords robes. You remember that, Bernie, don't you? And I felt extremely embarrassed actually that the alarm went off at that point.
Very, very well indeed.
Yeah. Anyway, thank you so much for the opportunity. And in the next half an hour or so, I can literally only scratch the surface of human factors. But actually, most of what I'm going to talk about is common sense application. And so many times when we go to work, we leave common sense at the front door. Now, my slide's not moving on for some reason. Let's see. Oh, now, why is that not moving on then? Oh, my apologies here. I can't seem to get my slide to move on. Let's just try that. Just going to try again. We tested this earlier and it was working fine. There we are. Okay, so apologies for that. So what I'm going to do is just give you a very short introduction to medical error. Much of this has been covered. Kevin's given a fantastic talk, really. And then I'm going to concentrate really on 2 areas. Individuals, so looking after ourselves, optimizing our own performance, and then looking at team performance, because we all work as part of teams, and a lot of errors occur within teams and things as well. So want to focus on those. And finally, a little bit about lowering hierarchy. We had a Royal College of Surgeons webinar last night with the English College President talking about hierarchy for an hour or so. So literally in this next 25 minutes, I can literally only scratch the surface. So thanks again, Bernie. So I'm a maxillofacial consultant based in Portsmouth. My eyes were opened to human factors about 9 or 10 years ago by an airline captain that had a string of every complication you can imagine, and just opened my eyes really with his friends coming to visit him in terms of communication and what have you. And since then, I've published probably about 80 or 90 papers now on safety, and a recent PhD. So this is the PhD. It's 270 pages, but actually, as I mentioned, most of it is just common sense application. That was a facial nerve, rather large salivary gland tumor, and there's the lady post-operatively. So that just epitomizes human factors. It was an 8-hour operation. yes, of course, we could work for 8 hours non-stop, but would we drive from London to Scotland non-stop without taking a break? Most of us wouldn't do that. We'd stop halfway through. And that was an 8-hour case. And I took 2 breaks during that operation. So it's human factors application. So Kevin already mentioned that the error is normal. So we make about 5 to 7 errors every single day, and that might be forgetting to put the washing machine on, leaving your phone at home when you go to work, leaving your sandwiches, what have you. But we make 5 to 7 mistakes a day on average. 1 in 20 hospital admissions has some form of error, and of those, 1 in 20 is a serious error. So 1 in 400 hospital admissions has some serious medical error. And just imagine if that was you or a member of your family. There's a very large study, a meta-analysis of nearly 350,000 patients published 2 years ago in the British Medical Journal. And errors are most common in operating theatres, in ICU, and prescribing mistakes. So the pen really is mightier than the sword in terms of prescribing, because it's killing more people than operating theatre error, in fact. So, you know, it's a massive, massive problem, and we need to do something about it. Kevin already mentioned an abbreviated Swiss cheese model. So errors actually start usually in an organization long before you operate on the wrong side, or you give that wrong drug. An error starts much further upstream. And most of my work has been looking at these so-called preconditions. So the factors that you can improve either in yourself or as part of a team to actually reduce that actual error from happening. That's, as I say, where most of my own work has been involved. I've been very lucky to work with a number of high reliability organizations. Here you can see some here, the Red Arrows, British Airways, National Air Traffic Services, and more recently, the Civil Aviation Authority. And I'm not comparing any of those with medicine or surgery at all. All I'm doing is I'm taking the human element from those organizations and bringing them into healthcare and applying some of the lessons and things that they've learned. So let's have a look at individual factors then, looking after ourselves. And there's only 2 things I want you to remember from my talk. And this is the first one. You know, when you get on an aeroplane, of course, none of us are flying these days with the COVID situation. Hopefully we'll get back to normal pretty soon. But one of the first things they say is, in the event of a depressurization, put your own mask on before helping others. And that for me is human factors in a nutshell. Look after yourself before looking after your patient. It sounds a little bit perverse, doesn't it? Looking after yourself first rather than your patient. But if you optimize your own performance, you will actually care for your patient so much better. And what do I mean by that? So this is one of my good friends. He's an enormous, great bodybuilder, as you can see. He tells me he doesn't take steroids, but I'm not going to argue with him really. But he's a nutrition expert. And what he says is that we need to eat regularly to optimize our brain performance. So how many of you don't have breakfast in the morning and you go to work and then you eat at lunchtime for the first time? Now, if you do that, you're not optimized. You're actually burning ketones. And there's been numerous large studies, for example, in the USA, of school children comparing 50,000 school children that had breakfast in the morning, 50,000 that didn't. And sure enough, those that had the breakfast performed so much better. And how many of us operate and we miss our lunch, or we're trying to lose a bit of weight, and so we don't eat lunch? And actually, you put weight on because you overcompensate in the evening and you eat more. Or we're rushing down the corridor and we're just eating a Mars bar. That's our lunch break because we're late for an outpatient clinic. That's not optimizing your performance. In fact, you're going to go hypoglycemic. You're going to get that insulin surge. So we need to take time and make time to look after ourselves. And it's not just eating. We're supposed to drink 1 to 2 liters of water per day. How many of us go home at the end of the day with a headache? And the answer is a lot of us. And one of the main reasons is because we don't have that 1 to 2 liters of water a day. Now, if you lose 1 to 3 kilograms in weight due to perspiration, water evaporation, your cognitive function falls by about 20%. Now, this happens very, very slowly, so you're not even aware that it's happening, but your cognitive function's falling off if you're not having regular drinks. So this is a P color-coded chart, and so we should really be in position number 2 or 3. We shouldn't be right down the bottom there with really concentrated urine. A fantastic study published 3 or 4 years ago in the BMJ, looking at ICU doctors and comparing their urine concentration to that of their patients. And because the doctors weren't taking their breaks and weren't drinking, their urine was more concentrated than the patients in ICU. So please, please, please drink regularly. It's really important, particularly during the summer. Short little article we published a couple of years ago in the British Medical Journal just about this, and this has had something like 200,000 downloads, but it's just obvious, isn't it, really? You know, looking after ourselves at work, eating and drinking regularly, and again, I just keep saying common sense application, but the number of times we forget to look after ourselves when we go to work. So anger is another one. So if you're angry, you know, we take our whole selves to work. So our emotional status, whatever's going on, we might have had a car accident, we might have had a marital disharmony, a row with someone, a parking dispute, something. You bring that emotion with you to work, and you're about 30 times more likely to make a mistake if you're angry or if you're emotionally charged. And there's something called a sentinel event. So something just tips you over the edge, and then you suddenly lash out at a colleague or a nurse or something in theatre, particularly when you're under a stressful environment. So, you know, if you're in that anger situation, you need to stand back from that situation. And I'll mention a mnemonic, which Kevin has already done. It's the HALT mnemonic. I'll show that in a second. And then tiredness. So believe it or not, if you're awake for 18 hours, you have the same cognitive function as being twice over the UK legal alcohol limit. So again, this just creeps up on us very, very slowly, and we're not even aware it's happening. And we think we're invincible and that we can work for 36 hours non-stop. We cannot do that safely. You know, our performance slowly starts to deteriorate. This was an unfortunate junior doctor who fell asleep at the wheel whilst driving home after a series of night shifts. Now, this error probably started in the organization. She wasn't given anywhere to sleep or to take a break prior to driving home. She fell asleep at the wheel and died at the scene. Absolutely tragic. So I would just float to you, how long do you think is safe to operate or to do a clinic? And the published data would seem to suggest 3 to 4 hours maximum before you need to take a short little break. And we've published on this ourselves, and you know, even things like microvascular anastomosis, free flaps and things, if you stop to take a break, the whole team takes a little break just for a few minutes, you actually catch that time up actually, and you know, you perform just so much better when you come back. So this mnemonic, tiredness can kill, take a break. We see that when we're driving on the motorway. Well, it really can, you know, so this is common sense there on the motorway. So please bring common sense to work with us. So HALT, as Kevin mentioned in his talk at the beginning, HALT stands for hungry, angry, late or lonely or tired. So those are the only 2 things really I would like you to remember. Put your own mask on first and HALT. And that really is the sort of key to understanding personal performance in human factors. Just want to talk a little bit then about team working, because we all work as part of teams, don't we, in surgery? So again, I only have a few minutes really to skirt over the surface of some of these. So I'm just going to talk about briefing, a little bit about communication and situation awareness, and then finally a bit about lowering hierarchy. I've been really lucky to spend quite a number of hours in the simulators with EasyJet and British Airways. And when your life depends on the briefing, you know, you actually deal with that briefing just so much differently than if your life or limb doesn't depend on it. And the BA guys have been into theatre and they've seen briefings, and you know, people pay lip service to the checklist, like yeah, that's enough. And this is one of the reasons why never events happen. I think it's really important, you know, right at the beginning to have a warm, open introduction so anyone can speak up if you have any concerns whatsoever, from the healthcare support worker right up to a consultant colleague. Anyone can challenge you and speak up without fear if they have any concerns. you should start thinking about the what if scenarios. So what might happen if Professor Smith, for example, puts a hole in the aorta, so he's then not going to get that startle reaction. He's actually thought it through. What are we going to do if this happens? He's got good situational awareness. Minimizing distraction is another really important thing. I'll mention that in a minute. And finally, plan those breaks with you and the team. If you think you can work for 7-8 hours, your team probably can't think that they can, and they may not want to even speak up and challenge you. Oh, Professor Brennan, please, can we take a break? You have to empower the team and look after the team. So with the COVID particularly, right, communication is 90% is non-verbal. So only 10% is actually verbal communication. So, I mean, particularly in the recent crisis, wearing the PPE, wearing the visor, we're losing a lot of those cues, if you like, so other people can understand, interpret what we're trying to say. So your body language and how you behave, it needs to be open. It needs to be warm and friendly. You need to have a two-way conversation rather than you telling people what's going to happen. It needs to be open. It needs to be clear, and I would suggest that you don't use pronouns such as I'm going to mix it as the cement, or I'm going to give it as the drug. Actually say what that drug is that you're going to give, or we need to do this operation or that. Actually say what you're going to do, and then there's no ambiguity. And ask for repeat back if you're not sure, if you want clarification. So just because what you've thought to say, then what you've said, that doesn't necessarily mean that the receiver has understood. So that repeat back's very, very useful. Say, for example, in carotid surgery, if you're working around the carotid tree and things, and you anaesthetist, that repeat back is really, really important. And so you understand each other. So let's just look at, say, aviation, just for example. And we talked this morning at the advisory board about drug errors. Well, this is in aviation. Here you are collecting your luggage. You're walking out of the airport. Have you collected your luggage? And then you're going through no return. It's absolutely clear. You're not going to leave your luggage behind unless you're completely blasé. Now just look at this. Here we've got adrenaline and amiodarone in almost identical packaging, and it would be so easy to pick up that wrong drug in the heat of the moment and inject it. And indeed that happens time and time and time again. And that's because the organizational influences, as I mentioned earlier, that's where that fault is starting. These drugs should not be packaged in that form. They should be totally separate colors or what have you, to ensure there's no ambiguity. So situational awareness then. So what does situational awareness actually mean? And that's something, for me, it means what's going on here and now, what's actually happened to bring us to this point. So we've had some fantastic talks, and what's going to happen in the future. So you may be thinking about dinner, what you're going to do this evening, going out for your run, or what have you. And that's what situational awareness is all about. It's a sort of dynamic event, if you like. And it's just not just for yourself, it's for the team as well. So I've been really lucky to work with the Red Arrows, and this is the most amazing picture taken by one of the Red Arrows, Steve Morris, Red 5. And if you look at his visor, he's got 5 arrows in front of him. Now, actually, subsequent to this, the Red Arrows have now banned selfies, taking selfies, and you can appreciate why, flying at 400 knots. But these guys have got amazing situational awareness, and I've taken some of those lessons and published on this as well. Absolutely amazing how they think. So this is how we can build situational awareness. If you have zero situational awareness at all, you're completely oblivious to what's going on around you. You've got no idea that Lord Ribeiro is going to cut off the wrong leg. You've got no idea. You're just oblivious. As you start to build your situational awareness, you notice what's going on. You then understand what's going on. And when you've got really good situational awareness, you're actively thinking ahead. As I mentioned earlier, you're thinking about those what if scenarios. You're thinking about what might happen. That's really good situational awareness. And then if you translate that across, if you've got really good SA, you're going to avoid error because you're thinking ahead and almost actively avoiding error. If you understand situational awareness a little bit more, but you're not at that level, you're going to trap the error before it progresses on. And if you're just oblivious, the error is going to happen, and then hopefully you can actually mitigate against any further consequences. So those are the different levels of situational awareness. Again, we don't have time to go into this in any more detail, but SA is really, really important both for you and for your team. So this is just an example in everyday life. You know, we buy and share milk in the department. You know, I'll bring in 4 pints of milk. So I want someone to tell me when we're getting low on milk about halfway up rather than right at the bottom. And then I go down to the shop and the shop's closed and we haven't got any milk left. That's good situational awareness. Tell me when we're getting low on milk halfway up rather than at the bottom. Obvious, really. So multitasking. All of us multitask. When you're driving home this evening and someone rings you, just have a think about that. And are you concentrating more on the phone call or the driving because you think you can do both to the same standard, but you actually can't? And either your driving will be impaired or you're not actually listening to the caller. But more importantly for surgery, manual dexterity is impaired. And look at prescribing errors. We had a nurse about 4 years ago who was using her mobile phone on the ward round texting, and she gave penicillin to a penicillin allergic patient. That's multitasking. Patient had anaphylaxis, ended up in ICU. So, you know, you cannot multitask. So we've actually done a number of studies, and this is a really important one, looking at distraction in the cardiac catheter lab. So a really high stakes environment, really, and we've used a NASA task load questionnaire. So we got approval from NASA to use this, and rather scarily, there was 190 procedures done. The cardiologist was distracted in over half of those angioplasties. Some of them were very minor, but actually 10 of those procedures were fairly serious distractions. Fortunately, no harm came to the patient, but it could have been so much worse. You know, if you get distracted, you are so much more likely to make a mistake. So we will introduce so-called sterile cockpit. So anything below 10,000 feet when you're flying in a commercial aeroplane, they only talk about procedure. They're not talking about what they're going to do for dinner or where they're going on holiday. They're only talking procedure. The cabin crew are not going to come in and bring them a cup of tea. They're only talking procedure. And you can apply that into the operating theatre and say at the team brief stage, you know, there may be safety critical times when I need to concentrate or we need to concentrate. Please, I just want peace and quiet. Turn the music down. I don't want to be distracted. And, you know, that can make a massive difference to your operative performance. So finally, then, just a couple of words about lowering hierarchy. Yes, there has to be a hierarchy in surgical teams, of course. So there has to be a consultant who is in charge for the patient. But it's a question of how we're actually perceived. And, you know, if that consultant is seen as that person there on the left-hand side and, you know, dictatorial, very steep gradient, would you as a more junior trainee be able to challenge that person if they were going to make a mistake? And the answer is you probably wouldn't, because you're too scared to speak up. So we have to actively lower hierarchical gradients. This is done very, very well on the flight deck. So the most senior captain there on the left and the most junior first officer, and that first officer can actively challenge the captain if they have any concerns at all. And if the captain says, right, shut up, I'm not listening to you, he or she would then be disciplined as a result. So, you know, we have to have the same across healthcare, really. You know, so many errors occur because people don't speak up. Now, there has to be balance and flexibility. So there may be emergencies where suddenly that hierarchy then has to go up steeply. So say a registrar or a trainee is operating, something goes wrong, you know, then the consultant has to take control and redeem the situation. So, you know, then the consultant will suddenly raise the hierarchy and things. So, you know, there does need to be flexibility. And again, just a very simple article that we published a couple of years ago in the British Medical Journal just empowering junior doctors and others, nurses, healthcare support workers, to speak up and challenge authority. And you should be able to challenge in a without fear of retribution. That's the key to it. So you may say something, and it is something silly, let's say, but the consultant's not going to say to you, "Oh, you're stupid, you shouldn't have said that." The response is, "Thank you very much for your suggestion or for your observation. Actually, it's this. And then the person doesn't feel silly. That's important. And I think respect. So respect is earned. So there's a certain amount of respect for being a foundation doctor, for being a consultant, for being Lord Ribeiro, for being whoever. But respect is actually earned. And if you give respect back to your team, they will respect you far, far more, and they'll be looking out for you as a result. And as we mentioned about good team situation awareness, if everyone's looking out for each other, error is much less likely. So just to bring everything together then, we are all fallible. We all make mistakes. And I say error is normal. Error is normal. As mentioned in the previous talk, we are all going to make mistakes. It's a question of being open, admitting to it, being honest. Don't ever lie to patients, always honest. But there's so much more we can do to optimize our own performance and that of the team. And again, I've only really been able to scratch the surface on that today. And if in doubt, just remember that halt. Halt means stop. Just remember that. Just stop. Step back from the situation, regroup as a team, and regain that situation awareness. And that might even mean, packing the wound, walking out of theatre for 5 or 10 minutes. Let's have a think about what we're going to do next. Maybe get a friend, get a colleague. We're just about to publish a paper on dual surgeon operating with a fantastic registrar, John Hardy, and some aviation people. So dual surgeon operating, particularly coming out of the pandemic, has a place for sure. Calling a friend. And that team working and actively lowering gradients. I know it's almost the middle of summer, but in the Christmas BMJ last year, we published an amusing article about Father Christmas and how he does human factors and empowering the reindeer, situation awareness, and how he falls off of roofs and things, and how he can regain that. So a short little article, but has a lot of important lessons to learn. That's freely available. So again, Frank and Lord Ribeiro, I'd just like to thank you very much for the opportunity. I tweet out regularly about human factors as well, so and often generates a lot of really interesting discussion and things there as well. So thank you so much indeed.
Well, thank you very much indeed. That was a very rich presentation and covered an awful lot of ground there, Peter. Frank, have we got some questions?
There are no questions, one or two complimentary comments. Peter, I'd just say thank you very much indeed. A tour de force and a quick whiz through it. And you, of all people, should know about falling off roofs, I have to say.
Yeah. For those of you who don't know, I had a so error can happen to anyone, and the end of last year I was cleaning the gutters, and I've done it for 10 years, and I put the ladder up carefully, and it's got big rubber feet. I got to the top on the very, very last gutter, and the bottom just slid away, and I fell 18 feet down a wall, broke 3 ribs, laceration, a tooth, a tibial plateau, 2 patellae and 2 toes, and I still don't know how it happened, but it's and whether it was my error or whatever, I don't know, but error happens, and it's but I lost my situation awareness, Frank, definitely. Yeah.
We hope
lucky to be alive
from your lessons, but thank you very much for a very entertaining and apposite lecture, Peter. And
no, thanks so much,
Lord Ribeiro, just to close the meeting down.
Yeah, well, can I say to all our speakers, well done. You've all kept the time and kept us really entertained and provided a huge amount of information to take away and to reflect on. I thought, Kevin, you kicked the ball rolling by bringing us up to date with what HSiB is doing and the experiences you've had working with that organization. And I think your reference to never events was key as well. to Tom Clutton-Brock, a data-rich presentation, I thought, and lots of lessons there for all of us to pick up on. And similarly, Jerard Ross, medical legal aspects of surgery. We talked a bit about Balgava and other cases, Celu, and I think we've all taken things that we will remember and learn from. And then Peter, as always, very, how should we say, humorous, a very good presentation, an awful lot of publications, as I said earlier on, and he keeps doing it. He doesn't stop there. He's always at it. And I thought his challenge without retribution was an important comment, because we must remember that juniors become seniors and end up looking after us. So we must make sure we don't challenge them and provide retribution in the process. I hope you've all enjoyed this afternoon. I certainly have. I've learned a huge amount, and I think we can take lessons away and hopefully implement those in our practice. So thank you all for attending. Thank you all for your contributions, our speakers. And if any of you would want to send any feedback through Frank, I'm sure you'd be delighted to receive it in whatever format you wish to send it. Thank you very much indeed for being with us this afternoon. Thank you. Bye, everyone.
Thank you.
Bye all. Bye, Ashok.
Bye. Bye.
Excellent. So what are you up to this afternoon then, Peter?
Oh, I'm on call tonight, so so I have to touch base with the team. We're doing quite a lot of work around the MRCS differential attainment, as you probably know. So we're looking, and we've got 2 or 3 more HF papers, and I've just managed to link up with the guy who's the Civil Aviation Authority advisor to human factors. So he'd like to get involved with us in the college. So absolutely brilliant. So it just seems to be going from strength to strength, to be honest.
Fantastic. Fantastic. It is quite interesting as an observation, and I should have made that point early on, that in the foundation of CORESS, many of the principal members were all aviators, Frank being, of course, an aviator, and that sort of hobby interest that people have had, you know, it makes a big difference in understanding human factors and the need to understand instruments and the whole. I mean, look at that cockpit, frightened the hell out of me.
Well, it's
so
just
instruments.
Yeah, it's that systems, isn't it? So it's ergonomics, basically. It's how you interact with systems and things. And so there's an ergonomics designer that I know quite well, and he's always talking about how can we improve flight deck design to actually make it more interesting. Because you sit on those sim checks, and it's just amazing. They'll introduce a fuel leak, for example. So there's a hydraulic failure. So they're all trying to sort out the hydraulics, and then he puts in a fuel leak as well. And they totally miss the fuel leak because they've become tunnel visioned. So it's that ergonomics of making that fuel leak apparent. You know, really fascinating. Really fascinating.
I mean, the one thing that we do have as surgeons when we have that tunnel vision is, fortunately, the anaesthetist at the top of the table saying, have you thought about that bleeding vessel down in the pelvis that you've ignored? You know, that's the difference. Frank, any comments?
I'm going to close the meeting down now to end the recording, and just thank you and everybody else who's participated. No doubt we'll talk outside the meeting.
We'll talk outside.
So thank you very much.
Thank you so much. Bye.
Thank you very much, Frank. Thanks, Frank.